This is Dr. Bill Massey, having another installment in our series on pharmacogenetics. Today, we're going to have a discussion about the use of pharmacogenetics and its importance in antiplatelet and anticoagulation therapy. These therapies are very important in a number of different disease states, and especially in preventing future strokes and preventing future heart attacks. And platelets are fragments of cells that float around in your bloodstream, and they respond to damages in your artery walls. When that happens, they become sticky and clump together, and that can form a thrombus, and a thrombus can cause a stroke or a heart attack. So in susceptible individuals, you need to be able to keep the blood thin so that it doesn't clot. And antiplatelet therapy is one of the more common ways to do that for prevention of stroke and heart attack. Clopidogrel is one of the most common drugs used for antiplatelet therapy. It used to be aspirin. Aspirin still is used very widely, but aspirin causes gastrointestinal side effects, and platelets and Plavix does not do that. So the issue, though, with Plavix is that it's inactive in the form in which you take it. That inactive form has to be converted in your liver to an active metabolite that actually causes the antiplatelet activity. Now, once it's converted into that active metabolite, then clopidogrel or Plavix has its effects. The issue with antiplatelet therapy and with anticoagulant therapy as well is that you don't want to get the blood too thin, or you increase the risk of a bleed. And a bleeding event can be a major thing. It can be life-threatening. It could be a hemorrhagic stroke. It could be a GI bleed. All of these have serious implications and usually require emergency intervention. Now, one of the issues about keeping that level of antiplatelet and anticoagulation therapy within that narrow window where it's active enough to prevent the formation of these clots and prevent strokes and heart attacks, and on the other side where it's not too thin so that you have the bleed risk, you really have to understand that it's being converted into this active form, and that needs to be done in a very controlled way. The problem with Plavix is that the enzyme that converts it to its active metabolite is highly variable between different individuals. And that variability can mean the difference between either not having an effect and making someone susceptible to a heart attack or stroke, or having too much of an effect and causing them to have a bleeding event. So in patients in which this enzymatic activity that converts Plavix from its inactive form to its active form is decreased, or even worse, it's non-existent, and that's not as uncommon as you think, then you're not getting any of the therapeutic benefit from Plavix. And then, of course, you're at risk for a heart attack or stroke. On the other hand, if you're one of the 28% of the population that have what we call ultra-rapid metabolism, then that particular patient that has that is going to convert it too rapidly. Their blood is going to be too thin, and it puts them at an 8.5-fold greater risk of a bleed event. That's 850% more likely to have a serious bleeding event. And again, that can be a stroke, or it can be a brain bleed, or it can be a GI bleed. So Plavix is very, very common. I mean, over 1 million people have coronary or stents put into their arteries each year. And $6 billion in sales. Clopidogrel is one of the most frequently prescribed drugs. It's also generic, so people are more likely to get it. 36% of the population have a variant in that gene that codes for the enzyme that converts Plavix to its active form that ends up resulting in a consensus-backed recommendation where clopidogrel is considered not effective and don't use it. And people that have that and get clopidogrel are at 2.4 greater risk of a cardiovascular event because of a lack of efficacy. On the other side of the equation, 28% of the population have a variant in the gene that codes for the enzyme that converts clopidogrel to its active form, so that they convert it too fast. The blood becomes too thin, and they're at an 8.5-fold risk, a greater risk of a bleeding event. And again, this is well known. FDA made clopidogrel, put the pharmacogenetic recommendations into their label to warn people about the variation between different individuals. Now, 30% of patients are resistant to clopidogrel. So what does this mean? Okay. What it means is that these people are going to have to be restented. They're going to have they may have a heart attack because of a lack of efficacy. And all of these are very, very expensive events and medical procedures that they would have to undergo because of their pharmacogenetic makeup. If you use PGX, you can reduce the risk of cardiovascular death and stroke and myocardial infarction. And again, $19,000 per bleeding event, and almost $41,000 per non-fatal heart attack, and $30,000 for a non-fatal stroke. These are very expensive consequences of not using pharmacogenetically guided therapy. So I wanted to give you these references that I used in the previous slide. You can look at these on your own. I won't dwell on them. So most drugs, 80% of drugs that we use, 80% of prescriptions, are affected by genes, genetic variation in genes that code for these liver enzymes that metabolize drug. But metabolize, I mean they just convert them into either their active form, as in the case of clopidogrel, or they inactivate them. A major metabolic enzyme family of the cytochrome P450 enzyme family. What they do, they're in your liver, and they usually make changes to drugs so that it makes them more polar, so that they're more easily excreted through the kidneys. Just a handful of those cytochrome P450 enzymes have a major impact on the majority of drugs. That's 1A2, 2C9, 2C19, which was the Plavix conversion enzyme, 2D6, 3A4, 3A5. And 90% of the prescriptions that we have that are made in the US are metabolized to some extent by these 6 enzymes. And as we know, in 2C19, the one that activates clopidogrel, we know that that is a major determinant of drug safety for use of clopidogrel, as well as the effectiveness of clopidogrel. So if you have normal activity, your risk of CV, cardiovascular death, MI, and ischemic stroke, 8%. If you have impaired function of that enzyme, which means you can't form the active metabolite, it's not as effective, then you're going to increase that to 10%. The risk of being restented more than doubles to 2.4%. If you have no activity or very little activity, you get almost no benefit from clopidogrel. You have almost a 60% increased risk of cardiovascular death, heart attack, or stroke. And your stent, your chance of being restented is almost 6 times greater. Now, these are major events that cost a lot of money, cause a lot of morbidity and mortality. The next group of drugs are the anticoagulation drugs. Anticoagulation drug, the most common one is warfarin. It's uses 25 million warfarin prescriptions. And again, you have to be very careful about warfarin because you don't want the blood to be too thin. You want to be able to clot when you need it, but you don't want to have a bleeding event. Again, because it can cause a bleed, there's a very narrow therapeutic window. I mean, we have to keep the warfarin concentrations within a very tight window of blood levels. And even patients that have the same issues can have a 10 to 20-fold difference in the warfarin dose that they need in order to stay within that range. 10 to 20-fold difference. That's a huge difference. And most of the variation in warfarin dosing is due to pharmacogenetics. Again, anticoagulation drugs are one of the most dangerous classes of drugs because of the risk of a bleeding event. 28% of those hospitalized that are on these drugs are hospitalized because of bleeding event. And the cost to treat is very expensive. And we know that if you use pharmacogenetics to guide drug selection and dose selection, that you lower these bleeding events almost by half and reduce hospitalizations for all causes in these patients by a third. Those are huge numbers that affect the health of these patients. And again, warfarin, like clopidogrel, has pharmacogenetic warnings in its labeling. Warfarin works through a different mechanism than antiplatelet activity. It actually blocks vitamin K reductase, which is the initiating event in the coagulation, the blood clumping cascade. Vitamin K reductase is coded for a gene called VOCOR-C1. And again, VOCOR-C1 is highly variable in how much of it is made between one person to the next. Warfarin inhibits vitamin K reductase, preventing the coagulation cascade and therefore keeping the blood thin. Warfarin is broken down and eliminated from the body through the cytochrome P450 isozyme 2C9. And 2C9, again, is variable in how much of it is produced from person to person. So with warfarin, you actually have two genes that code for two different proteins, one a metabolizing enzyme, one involved in the actual anticoagulation cascade. And you have to look at both of those genes to get a good idea of how you would dose warfarin in a patient. So the gene 2C9, 40% of the population are intermediate metabolizers. So in intermediate metabolizers, warfarin levels are stay higher than in someone who has normal metabolism. Requires a dose adjustment. And again, these are in the labels for warfarin and warfarin analogs. There are different types of warfarins and they have different dosages. But you need to look at the dosage tables in order to give the most appropriate and safe warfarin dose. Poor metabolizers, much smaller percent of the population, but they essentially don't break down warfarin, and the warfarin levels stay very high, again, increasing the risk of too much anticoagulation and a bleed. Now, the other thing that affects warfarin dosage is how much vitamin K reductase is actually expressed. So if you have a lot of vitamin K reductase expressed, this will require more warfarin to have the full anticoagulation effect. About 25% of the variation in stable warfarin doses are due to the expression of vitamin K reductase, the differences in expression. People are highly sensitive. That means that essentially they don't express very much vitamin K reductase, and people are have low sensitivity to warfarin express little. So I just want to thank you for your attention on this one, and I look forward to doing future installments in this series on pharmacogenetics.